Good afternoon. My study is a comparative study of clinical profile of refractive errors in preterm and full-term children. Normal retinal vascular development usually begins as early as 16 weeks of gestation, which remains incomplete until term, that is around 40 weeks. So in premature delivery, that is in preterm, where retina is still in the process of development, with exposure to additional risk factors including oxygen therapy and NICU interventions, there occur retinal vascular ischemia, hypoxia and hypoplasia, which all leads to abnormal retinal development. This is simply the pathophysiology of retinopathy of prematurity, which is a leading cause of childhood blindness. With increasing survival rate of preterm, there is an increasing prevalence of ROP. Early screening and timely treatment of ROP are critical. Whether it is preterm or term, children need regular ocular evaluation to detect refractive errors early, because long-term visual outcomes are affected by the refractive errors. In our study, we are exploring the relationship between preterm birth, ROP and refractive errors, comparing the refractive status between preterm and term children. We conducted a retrospective analysis of 500 children, that is 250 preterm and 250 term, over a period of 6 years at our institute. We assessed the presence and severity of ROP by fundus examination, and we evaluated the refractive errors by cyclopegic refraction, and we recorded the findings every 6 months. So the result. So in preterm and term babies, 70% of babies found of babies found to have refractive errors at 6 months, and in term babies, 35% of babies found to have refractive errors. We advised observation for both this group. This is the refractive profile obtained at 6 months of age in the study population. Considering the fact that children are typically hyperopic at birth, overall the preterm babies have higher prevalence of refractive errors like myopia and astigmatism than the term children. So this shows the treatment approach among preterm and term babies at 6 months, 1 year and 5 years of age. At 6 months, we advised observation. At 1 year, in preterm babies, 15 out of 250, that is 6% needed glasses, and in 5 years, 98, that is 39.2% required glasses by the age of 5 years in preterm babies, whereas in term babies, 25 out of 250, that is 10% required glasses by the age of 5 years. This shows refractive correction needed among the preterm and term babies at 1 and 5 years of age. This shows there is a progression at 5 years of age. How the impact of ROP on refractive errors? In our study, out of 250, 54 babies were diagnosed with the ROP, and out of these 54 babies, 40 recur refractive error correction at the age of 5 years. This table shows the refractive error correction based on the treatment status. Out of 54 ROP babies, 10 who underwent non-treatment and 44 who underwent treatment. Out of 10 who underwent no treatment, 4 recurs refractive error correction by the age of 5 years, and out of 44 who underwent treatment, 36 recur refractive error correction. This ROP babies recur refractive correction based on the treatment state. So in out of 10 ROP babies who underwent no refractive correction, 4 recur refractive corrections. Out of 34 post-laser treatment ROP babies, 28 needed glasses, whereas out of 10 post-injection babies, 8 requires glasses. This shows how the severity of ROP, how the severity of refractive errors increases with the severity of ROP. Coming into discussion, there are various studies. In the study 2015 by McDonald et al., there is ROP and prematurity contribute to increased incidence of refractive errors in children, and in 2017 study, preterm children, especially those with the ROP, have higher prevalence of myopia, and in 2006 O'Connell et al. Study, preterm infants show higher rates of refractive errors at school age with the refractive measures needed. In our study, we also found out that there is increased prevalence of refractive errors in preterm babies than term babies, and there is also higher risk of refractive errors in infants with ROP, and risk increases with the severity of ROP. There is also persistence and progression of refractive errors noted, that is 6% needed glasses by the age of 1 year in preterm, which progressed to 39.2% by the age of 5 years. Refractive errors tend to persist and worsen over time. In full-term babies, there is lower and less progressive prevalence of refractive errors noted. There is also the role of gestational age and birth weight, because more premature and lower birth weight infants have already at a higher risk of developing ROP, so as refractive errors. KSOS test is used for the comparison of refractive errors between term and preterm babies. We get a p-value of less than 0.05, which indicates its statistical significance. So preterm infants have a significantly higher prevalence of refractive errors, and preterm birth and ROP increases the risk of refractive errors. So in conclusion, Our study strongly emphasizes that preterm birth ROP, there is a strong link between preterm birth and ROP and higher prevalence of refractive errors in preterm than ROP. Many studies which solely focus on the refractive errors in babies with the ROP, whereas our study compares refractive errors in preterm babies whether they have ROP or not they have ROP with those in full-term babies. This provides a broader view of the impact of prematurity on refractive errors. So in conclusion, whether it's a preterm or term, all babies need yearly and routine eye examination, with the preterm babies requiring closer follow-up and regular reviews due to their higher risk of refractive errors. These are my references. Thank you.
These preterm babies were given ROP, with ROP, were given treatment or not?
Yes, sir. 50 out of in our study there are 250 preterm babies. 54 were diagnosed with ROP. Out of this 54, 44 underwent treatment. There is 38 who underwent injection laser treatment and 10 underwent injection treatment.
Treated patients had what type of staging grade? Stage 1 or 2?
Stage 2 and stage 2, 3 and 4. Sir.
4?
Retinal.
Stage 4?
Stage 3.
Normally, metropization occurs at what age?
In preschool, 3 years.
Why do you prefer cycloplegic refraction children?
To know the correct refractive errors, to paralyze the ciliary muscle, we can block the accommodation.
How much accommodation in children? Total even up to 6 to 8 they have first.
Thank you.